Thank you very much, Dr. Salim Wadani, for presenting an update on your project. We're very pleased to report the two studies by Dr. Salim and Dr. Moed Khlewi, and then I'll give you an update on the status of the residents and fellows projects, which we are really proud of. So Dr. Salim will be presenting on prevalence and outcome of acute kidney injury in cirrhotic patients admitted to the ICU. Dr. Salim.
Yes, hello everyone. My name is Salim Badani. As both Yasin said, my project is about prevalence and outcomes of acute kidney injury in cirrhotic patients admitted to intensive care unit. So I'll start with the definition for the liver cirrhosis as an advanced stage of liver fibrosis due to chronic injury that would lead to deranged function of liver and multi-system involvement due to its complication either directly or indirectly, which eventually lead to increased morbidity and mortality. Acute kidney injury is an acute decline in renal function and renal filtration function, and it is a common associated complication of liver cirrhosis. Systematic review and meta-analysis done in 2016 showed that acute kidney injury occurred in about 29% of patients with cirrhosis admitted to hospital. And it was associated with six-fold increased risk of in-hospital mortality. So the mortality in that study was around 34% in AKI group and 9.7% in non-AKI group. So we came up with this study to determine the prevalence and outcome of acute kidney injury in cirrhotic patients admitted to our ICU. So it is our study design is a retrospective cohort study of prospective collected data from 1999 to 2017. We used our database and we compared the cirrhotic patients with AKI and those who doesn't have AKI using Kaligo criteria. The data was collected from a secure database maintained in our ICU. We included all cirrhotic patients with age more than 14 years. We exclude patients who's known to have end-stage renal disease. So patients were grouped into AKI and non-AKI group. We use for analysis SAS version 9 and SAS Institute. For the continuous variable, we present it as median with interquartile ranges, while the categorical variables are presented as mean and standard deviation. The chi-score or ANOVA was used to test significant difference between study groups. Also, we did the multivariate regression to predict in-hospital mortality, adjusting for the variables for statistically and clinical significance. So we had total of 1,397 patients with cirrhosis, and the AKI incidence was around 52.9%. Most of them were stage 3 AKI. And then AKI group was around 47%. So we then baseline characteristics of those patients. So the mean age for the non-AKI group was around 60, while with AKI group it's different from stage to stage. And stage 1 was 65 years and 63 and 64 on stage 3. Most of our patients were male. For the body mass index, it was higher on stage 3 AKI group. We had different admission categories. Most of our patients were admitted under cardiac. So the most common chronic disease was associated with AKI in our group was diabetes, and it is correlated with or increases the risk of AKI. And also we have other chronic diseases, but the most common was diabetes. Also, the Apache, we also see one of the variables is Apache score. It was highest in stage 3 AKI with median of 31, while the non-AKI group was the median was 22. Also, creatinine, which will go up as the patient have advanced stage of acute kidney injury. For the lactic acid, also the median was 4.6 in stage 3 versus 2.5 in non-AKI group. Also, INR was the highest in the stage 3 AKI group, and the bilirubin as well. And this ratio was 185 in stage 3 AKI group versus 256 in non-AKI group. For the outcomes, for ICU mortality was highest in stage 3 AKI group. It was around 53% versus 34% in non-AKI group. Also, hospital mortality was high in stage 3 AKI group. It was 72% versus 49% in non-AKI group. Patient with advanced AKI was more addressed as no code status. And for the ICU length of the stay and hospital stay, it was higher in AKI group versus the non-AKI group. Renal replacement and vasopressor was high in stage 3 AKI group. For the multivariate regression analysis, we have predictors of hospital mortality. For the age, each 1 year increase in age increases the mortality by 2%. Patients with vasopressor are more prone to, or they have higher mortality by 70%. Apache score, we notice that each 1 unit increase in Apache score increases the mortality by 10%. DINR increases the mortality by 18%, and lactic acid increases the mortality by 8%. So in summary, the incidence of AKI in our study was 52.9%. The ICU mortality was 47% in AKI group versus 34% in non-AKI group. Length of ICU stay was higher in AKI group with median 4.5 compared with non-AKI group, it was 3. Diabetes was the commonest chronic disease. The risk factor for hospital mortality were age, vasopressors, and INR, lactic acid, and Apache type 2. So, to compare to the literature, the incidence of AKI in our study was higher than what is in the literature, and this could be due to complexity and severity of our patients, since all of them are critically ill patients. Also, the cause of liver cirrhosis in our region, hepatitis, while in the western area, chronic alcoholic consumption as well. And the hepatitis also can affect the kidney directly, not like alcohol. So population are different. Or overall, this could contribute to this higher incidence of AKI. Mortality in critically ill cirrhotic patients is high and decreases more in presence of AKI, which correlates with literature. We have several limitations of our study. So it is a retrospective study. Unfortunately, we don't know what causes the liver cirrhosis. Also, we couldn't measure the child blood score, and we don't know the baseline creatinine of our patients. We assume it with formula, and patients with liver cirrhosis have a lower muscular mass, so AKI could be underestimated. And this is the end of my presentation. I would like to thank the research team, and thank you guys for listening.
Thank you, Dr. Salim, for this excellent presentation. We'll open it for questions. So maybe I will start. You mentioned one of the reasons for having higher incidence or high prevalence of acute kidney injury in our population is the etiology of liver disease. That it's we have more hepatitis C compared to Western studies where they have more alcoholic hepatitis. Any other reasons why AKI is more common? Based on your data?
Yeah. Also, the Apache score, the median of Apache score in our study was patients with CGP, they have 31 median of Apache score, while in the other studies it's less than 30. So the severity of the disease of our patients is sicker. This is one. The second thing is our patients are older than the Western population. I'm talking about liver cirrhosis. So our patients are older and having more comorbidity and more chronic medical diseases. While in Western area, they are the most common cause was alcoholic consumption, and the patients are younger.
Good. I think the high prevalence of diabetes is striking also. So high prevalence of diabetes increases risk of AKI.
Yes.
Correct?
Yes. The diabetes was for around 43% of stage 3 AKI group, while in AKI group it was 25%. It was statistically significant.
Yeah, very good. Other questions? What do you think about the BMI? Can you go to the previous slide? How do you explain that patients with worse acute kidney injury have higher BMI?
Well, BMI and stage 3 was 31.2%, or 31.2, while while non-AKI was 26. It was statistically significant.
So do you think the sicker patients are more obese?
Yeah, it could be like this, but
any other explanation? I think another explanation, they had fluid retention.
Oh, yeah, it could be one of the reasons.
Yeah, most likely, actually. So the patients with, so they are not really more obese, they have more fluid because of the acute kidney injury and because they have more severe cirrhosis, more ascites, more edema. Any other questions from the audience, comments, Dr. Salim? So what's your plans with this study? Where do you stand with writing this paper?
I'm almost finishing the manuscript, and I will try to publish it. Inshallah.
Comments for Dr. Salim, suggestions? If you have comment, you can raise your hand, so unmute. Do you have the predictors for, did we do predictors for the AKI?
No, only for the hospital mortality.
Yeah, might be something interesting to look at. Predictors of AKI. Okay, sounds good. Any other comments, suggestions? This is a large, so some of the strength thing, it's a really large study. How many patients can you go back? This is
1,397.
Yeah, this is one of the largest studies on cirrhosis. This is really very impressive. Big study, very striking findings. Actually, how severe these patients, how commonly they have kidney injury, the high correlation between kidney injury and other organ dysfunction, more lower PF ratio, higher INR, lower platelets, all correlate very nicely. So good work, Dr. Salim. Any other comments for Dr. Salim? If not, we'll move on to Dr. Moed Khlawi, who will present another topic also related to cirrhosis. Dr. Moed. Thank you, Salim, very much. Really great work.
مرحبا.
حياك الله دكتور مؤيد.
الله يحييك يبقيك. أنا كنت host disabled participants. Okay. I think I should be a co-host, right?
Yes. You're co-host or not?
No, not yet.
طيب شوفوا إذا فيني أنا أسوي كده. Rose, can you make Dr. Moyed co-host? I'm not sure I'm able to do it.
Yes, doctor. He's one of the co-hosts now.
No, he exited and came back.
Okay, I will do. Where is he? Okay.
You are co-host now.
Okay. So I will go to.
Doctor, yeah.
Yeah. You are seeing the screen, right?
Yes.
Okay.
بس لو تحط على الفول screen. So Dr. Moyed was a fellow when he did this study. He's now in the cardiovascular ICU cardiac sciences in King Abdulaziz Medical City, associate consultant. And hopefully soon will be a full consultant, doing great job there. And he did a fantastic job in getting this paper together. So Moyed, تفضل.
Assalamu alaikum. مساك الله خير. Thank you, Dr. Yassin, for your introduction. Our research project was done last year with the prof and other colleague, which was the outcome of cirrhotic patient admitted to the ICU after successful resuscitation of the cardiac arrest. The list of the co-authors: Prof. Yassin, Dr. Hassan Durzi, Dr. Farhan, Dr. Hani Tamim, Dr. Musharraf, Dr. Muhammad Farhat, and Mrs. Filwa. Special thank for her actually job and arrangement and everything for her. Thank you, Mrs. Filwa. So background: despite advancement in the critical care and emergency, survival to hospital discharge after successful resuscitation of the cardiac arrest remains low. Data on the outcome of patient cirrhosis are very scarce and they are very limited. We don't have much data internationally and nationally as well. So our objective of this study was to evaluate the outcome of the cirrhotic patient admitted to the ICU following cardiac arrest. So the method was a retrospective study of all patients admitted after successful resuscitation of the cardiac arrest to the ICU of a tertiary care hospital between 1999 and 2017. And the characteristics of the hospital survival, non-survival were compared. We have now all the baseline characteristics of the patient, the survival and non-survival, the age, the gender, the comorbidities, diabetes, chronic disease, respiratory disease, chronic renal disease, immunocompromised, chronic cardiac, mechanical ventilator, and vasopressor Apache score as well. So from this slide, we see that they are a pretty sick patient. They have comorbidities and they are not young age group. They are elderly. The median is like from all the patients is 64. So the baseline of the after of all these patient variable of these patient exactly bilirubin, GCS and creatinine. If we see the number we are having, we see these variable once they are there, the risk of the bad outcome is there. Now we'll go to the logistic regression and we see more exactly with this patient exactly. So here the outcome of the patient. The one died in the ICU 54. The median length of stay is 2.2. Hospital length of stay is like 10 days. Mechanical ventilation is 3 days. Tracheostomy is 10. Here we have the main predictor of death. We have the age of the ratio of 0.9, Apache score of like everyone increase, and the Apache score there is 21% of risk of death. And there is also bilirubin increase, and bilirubin will increase the mortality of in-hospital mortality of 2% as well. So now go to discussion. The prevalence of cirrhosis in the ICU range from 4 to 7 of a critically ill patient. We report hospital mortality of 88 for patients with cirrhosis and who had a cardiac arrest. Another study done by Rodale was reported a rate of mortality of 79 in cirrhotic patient compared to 50% non-cirrhotic patient, which is around close to our percentage of mortality, almost close. In addition, they reported that the group with liver cirrhosis survived had poor neurological outcome. So the factors that may have resulted in this difference include various causes and risk factor of liver cirrhosis in Saudi Arabia. And as we know, the most reason for cirrhosis in our population are like infective cause compared to Western country and European country, which is alcoholic mainly, which have poor prognosis, the infective cause of cirrhosis. The Apache score probably indicates severe liver disease, hence a significant association with increased mortality. The median score of this group with the worst outcome was 38 compared to 24 in the group who survived. Several studies about a similar negative outcome of patients of severe liver disease indicate the current study by the Apache score and the current and the cardiac arrest as well. Also, our study indicated that the use of mechanical ventilation, low GCS, and high level of lactic acid were associated with increased mortality. Of the 73 patients who were mechanically ventilated, 6-7 died and 6 survived. The group with the worst outcome had GCS of median of 3, and compared to the group of survival of GCS of 10. Similarly, with high level of lactic acid with the group, a median 6.4 lactic acid had worse outcome compared to the survival of 2.9. So the literature reporting these parameters with which to compare our results are not available. And also the sample size of current study was 76, which is high. But we need larger sample to see more accurate result. Despite this number is a good number actually. 76 is good. And we need prospective multi-center study and data containing more detailed score, such as not Apache 2 score, no. The child score are required to be more clear and more more specific score for the liver disease exactly. In conclusion, cirrhotic patients who had successful resuscitation after cardiac arrest have high mortality, high Apache score, and high bilirubin, low G score, have high lactic acid, and use mechanical ventilation, all associated with the increased mortality. And by this, I conclude. If you have any question.
Thank you very much, Dr. Mohamed. Great presentation. What's the status of this paper?
So this paper, thankfully, alhamdulillah, after effort of all of you, Prof. Yassin and Dr. Hassan, is got published in the Saudi Journal of Medicine, and will be issued in the next available issue, inshallah. Already accepted for publication.
Yes, congratulations, fantastic effort. Dr. Khalid Al-Maghribi, you have a comment?
I have a question. Assalamu alaikum. Just two questions actually. Number one, these lab results, was it pre-arrest or post-arrest? At what time you have it? And the other thing, do we know what's the initial rhythm those patients they have when they got the cardiac arrest?
Yeah. So this number we have of the patient who survived or not survived, but the number we are having of the patient who after the cardiac arrest. So this number we are comparing to the patient who survived after the cardiac arrest. So all this number of the patient who had the cardiac arrest, then we have a number.
So this is the first 24 hours in the ICU?
Yes.
Post cardiac arrest?
Yes.
How about the rhythm, Dr. Moyen?
Yeah, we have non-shockable rhythm we are having. That's what we are reported. We have non-shockable rhythm, all our patients.
Yeah. Sounds good. Any other comments? So again, it's a large sample size for this kind of
Exactly.
This is really very informative. Striking severity of illness, Apache of 34 or something, very, very high. So this very critical group. One of the reason of high mortality also, I think, should address the issue of goals of care, that maybe some of these patients should have been goals of care, perhaps in other places would have been addressed earlier. Is that possibility, Moyad?
Yes, yes.
Yeah. So these are very sick patients, and maybe, I mean, the goals of care should have been addressed.
Yeah.
Any comments? I think it's also flows nicely with the previous paper about the acute kidney injury, where you have a lot of patients with acute kidney injury, high creatinine, and high severity of illness. It's really the same pattern. So these patients come to ICU cirrhosis are very critically ill.
Exactly, yes.
Very good. I think this really great example of a study done by residents and fellows and was reached to the final publication. And I think this is a good model for all our trainees. So congratulations, Dr. Moyed and Salim, for this great work.
Thank you, Doctor. And actually, without your effort and help, we could not reach at this point exactly at all. You gave us a support and help, and we are just keep emailing you, texting you, WhatsApp meeting, frequent meeting. Without you, we could not make it, Doctor. Thank you so much.
Great job. So with this, I want to share with you the progress on different overall progress on residents and fellows. And I would like to invite the residents and fellows to continue their excellent work like the one we've seen with Dr. Moyed and Dr. Salim today. So we have, at present, we have 29 projects for residents and fellows. Some of them, 16 of them submitted to IRB and 13 still in the proposal writing process. There are 14 proposals accepted by IRBs and 8 have completed analysis. We have several of them presented in the in this meeting before. Preliminary analysis for 5. There are 12 papers being under writing at different stages. And we heard from Dr. Moyed the paper was submitted and accepted, but there are 3 others are now in the pipeline. Hopefully soon will be submitted. And there are 9 written, but they need additional work. So making good progress, and I would like to encourage all the residents and fellows in all programs actually to make this a priority, to have a research project. So this is the one by Dr. Moyed, the Saudi Medical Journal, which is fantastic achievement. And there are 2 of our residents, 1 resident and 1 fellow, submitted their abstracts to the American Thoracic Society a few days ago. And I'm almost certain this will be accepted. Really high quality projects, non-invasive ventilation in patients with severe acute respiratory infection. And 1 about the combination of norepinephrine with phenylephrine versus norepinephrine with vasopressin in patients with septic shock. It's a retrospective study, but it's a good methodology. So with this, I'd like to thank you. And if there are comments or suggestions, happy to take them. Okay. We're supposed to have a 3rd presentation, but we had to postpone it. So today we'll have a shorter meeting than usual. And I like to thank you all for attending, and great work, everyone. Have a good night. Bye-bye.
شكرا دكتور ياسين.
يا حياك الله. مع السلامة.